It's in the budget to no longer fund state offices of rural health. And I think that that's a catastrophe. Rural health clinics are very reliant on their state offices of rural health. And so we are really hoping that that doesn't happen.
Hello, one and all, and welcome back to The Real Impact. You know, we are the podcast that works hard. We really do, to connect the dots between policy and rural everything. I am Michelle Rathman, and I am forever grateful. And I mean that you have carved out time in your very busy schedule to join us. And we're so appreciative for our growing community of listeners and subscribers. And listen, real quick, if you've not yet subscribed, you can do that by visiting theruralimpact.com. It takes 2 seconds, and then you will be sure to receive updates and information about upcoming shows and resources and all that good stuff right in your inbox. Okay, so today, it has been just over a week since the passing of H.R. 1. And as you know, that is known as the One Big Beautiful Bill Act. And so today's episode, we're going to do a little bit of a shift from looking at what could happen should it pass to what is and will happen and is anticipated to happen now that it has been signed into law. Again, it's just been about a week or so. So things are still being sorted out, as you'll hear in this episode. But first, a really quick overview, in case you have not been following along in this 870 or so page bill. It includes making permanent several provisions of the 2017 tax cuts, overhauls, understatement, overhauls of Medicaid eligibility, and increases funding for military and immigration enforcement, while also rolling back certain clean energy subsidies and adding an estimated $2.4 trillion to $3.1 trillion to the national deficit, something that's important for us to keep in mind. So for today's discussion, I'll note that the H.R. 1 includes some of the harshest restrictions to Medicaid and SNAP ever, imposing stringent new work and reporting requirements on both Medicaid and SNAP recipients, and that includes children. And for Medicaid, it reduces federal matching funds, for example, increases cost sharing for those above the federal poverty line. And bottom line, it cuts roughly $863 billion from Medicaid and nearly $295 billion from SNAP over the next decade. And sometimes we're trying to just figure out how we're going to get through tomorrow. So it might be a little bit difficult to think about what's going to happen 10 years from now. But down this course, this is the kind of cuts that we're looking at with really nowhere to look to see where that might be supplemented. So to help us sort through all of this, I have invited quite the lineup of experts to include in this conversation, because all of them much smarter than me with a lot more detail to share. So we've invited old friend of the podcast, Edwin Park, research professor at the Georgetown University McCourt School of Public Policy. I'm also thrilled to be joined by Shawn Martin, and Shawn Martin is the Executive Vice President and Chief Executive Officer for the American Academy of Family Physicians. And finally, we welcome Nathan Baugh, and Nathan is the Executive Director of the National Association of Rural Health Clinics. We have not had Nathan on before, but we're so glad that he is here to explain what all this means for those rural health clinics you might be served yourself by in your rural community. So with that, it is time, as I always do, invite you to tune out that background noise and put yourself in that podcast frame listening of mind, and listen to my first OBBA explainer conversation with a guy who knows more about Medicaid, Medicare, and CHIP than anyone else I know, Mr. Edwin Park. Are you ready? You know I always am, so let's go. Edwin Park, research professor at Georgetown University McCourt School of Public Policy, and my new phone friend, which I really appreciate. Welcome back to The Real Impact. We are very grateful that you're here today.
Thank you, Michelle. Thank you for having me.
All right. So before the passing and signing into law of H.R. 1, we all know it as the One Big Beautiful Bill Act, there was an enormous effort put out by yourself, your colleagues, so many of us out here working in rural health And the reason why we're talking about this is because it's just still so fresh. The wound is still very wide open. And we put out a lot of information to educate lawmakers about just how devastating, as you put it so often, these draconian cuts are going to be for rural America, rural hospitals, rural providers, and people who live there who rely on Medicaid as their only source of insurance, for health coverage. So now that it's law, I thought, Edwin, that you could help our listeners better understand the numbers, even as we're still trying to figure that out, because there are a lot of numbers out there, a lot of varying, X amount of million people will lose their coverage and so forth. So could you just kind of lay out what you know, and you know a lot?
Sure. So there are many last minute changes made to the budget reconciliation bill and its Medicaid and CHIP provisions. So despite being passed by Congress, signed by the president into law, we still don't have final numbers from the Congressional Budget Office in terms of the size of the cuts, how many more people will be uninsured. We have a good sense of how large these cuts are. This will be the largest cut to the Medicaid program in history, the largest rollback in health coverage in history. It's probably going to be in the order of about $1 trillion in Medicaid cuts, and 16, maybe 17 million more uninsured by the end of the decade as a result of this legislation.
Mm-hmm. And now I wonder, and this is something I was listening to this morning on Julie Ravner's What the Health podcast, which I listen to all the time, talking about some new provisions around removing legal immigrants who have legal status and completely eliminating them from all of this as well. So I don't know if these numbers were included in this bill or not, or is this still kind of an ongoing process?
Yeah, we hope that all those numbers will be included in the final Congressional Budget Office estimates. But this legislation takes away not only Medicaid and CHIP coverage, also marketplace coverage, and also Medicare coverage from many lawfully present immigrants. And this includes refugees, asylees, victims of domestic violence and human trafficking, a whole host of people who are, very vulnerable, who've had access to various forms of federal health coverage, including Medicaid, for decades.
Mm. And so at the end of the day, we know with absolute certainty one thing: those who are uninsured will still need health care, bottom line. And so let's talk a little bit about what this means, just based on what you're seeing. I mean, we talk about rural hospitals being on the brink of closure. We've been doing it for a long time, but this takes it to a whole new level. What do you foresee the impact just on the finances? Because lest we forget, there was a provision that was thrown in kind of in the end about a $50 billion rural transformation fund. No one really understands how that's going to work. What are you seeing in terms of, first of all, will it even make a dent on now hospitals having to care for a whole new group of uninsured population and their finances being taken double, triple hits?
Yeah, I mean, we know that some estimates of a slightly earlier version of the legislation from KFF is that federal Medicaid spending will probably fall by about $155 billion over 10 years. And separately, the Urban Institute estimates that rural hospitals will see revenue losses of about $87 billion over 10 years and an increase in uncompensated care costs by about $23 billion. So a total of $110 billion hit. To give you a sense in comparison, this Rural Health Transformation Fund, which was touted as a way to mitigate the harm to rural hospitals and rural health systems, is really a fig leaf. It's only $50 billion compared to the numbers I just gave you, so it's much smaller. It's temporary. It's only for 5 years rather than permanent. These cuts are permanent. They're going to get bigger over time. And it's really poorly targeted. Half the money is divided equally across all states, irrespective of their need, the number of rural hospitals, rural residents in their states. And then the other half is really divvied up at the discretion of the secretary. It has to go to only, at minimum, a quarter of the states. The criteria are very vague. There's no set formula for divvying up the dollars. And in fact, how the funds are allocated is specifically exempted from judicial and administrative review. And if you look at some of the purposes for these funds, Some of them are about payments to rural health systems, helping rural health systems, but some of the permitted purposes have nothing to do with rural health systems. It's about chronic disease generally, which is one of Secretary Kennedy's priorities. It's about technology, cybersecurity even. And so even though the purpose that about providing payments to providers doesn't actually specify rural, just says payments to providers. And we know from reporting that Dr. Oz, the CMS administrator, was telling House Republican members, oh, don't worry, even if your district isn't a rural district, I'll still send you money from this fund. So it's hard to see how this fund could really make a big dent in the harm that rural hospitals, rural health systems, and rural communities will face under the legislation.
And you all will forgive my skepticism in terms of transparency, because I don't think we're really going to know. I mean, if we don't know on the front end, we're certainly not going to know on the back end. Edwin, I want to talk to you a little bit about Medicaid expansion states. And this is something that really confused me to begin with. Listen, I'm not as deep into this by any stretch of the imagination, but Medicaid expansion states are expected to fare far worse in this legislation, which is confusing. So I wanted to have you kind of explain to us kind of big picture of why this is so.
Yeah, it's very clear that for Republican leaders in Congress and the administration, that one of the goals of the health cuts in this legislation is to really undermine the Affordable Care Act's Medicaid expansion. That this was something that was ultimately unsuccessful back in 2017 in the first term of the Trump administration. But according to KFF, roughly half the cuts are targeted specifically at the Medicaid expansion. So this includes provisions that really scale back the ability of states to finance their share of the cost of Medicaid through so-called provider taxes. That's specifically one provision related to provider taxes specifically targeted at expansion states. The work requirements, which are going to add a lot of red tape, drive off eligible people off the program, even though they remain eligible, they're actually working or they should be exempt, but they can't navigate the really complicated systems as part of work requirements. That's just for those eligible for the expansion. There are requirements that states have to more frequently renew coverage for those in the expansion 6 months rather than the 12 months that applies for everyone else. And we know from unwinding of the continuous coverage protection during the pandemic, if there's a lot of red tape, you have to go through renewals. There's a bunch of people who get terminated from coverage for procedural reasons. Again, not because they're no longer eligible, but because of paperwork, problems meeting deadlines, complicated systems that they can't navigate in terms of reporting their paperwork, verifying that they're still eligible. And so, these are really all provisions targeted at the Medicaid expansion as an attempt to really undermine it if they weren't able to go directly at the expansion. And so some of the proposals that were originally under consideration would have capped federal funding, targeted the Medicaid expansion, eliminated the current 90% matching rate, which is the percentage of cost of the expansion that's picked up by the federal government, which would really force states to drop the expansion very soon. They weren't able to get those provisions in this law, but many of these other provisions are an attempt to move in that direction to really make it harder for states to continue their expansions and for those who are eligible for the expansion to be enrolled in the expansion.
I read something yesterday, and it's so true. This does not save anything. It just shifts the burden. So let's talk about that for a moment, because we're talking the federal piece of this, but what's it going to look like for states that already are just, they've got hospitals closing left and right. So what is it going to look like at the state level? Because you kind of have a theory we talked about before, is that now not only will it shift the burden, but the blame as well. When it comes time to really unpack all this, who's going to be to blame?
Yeah, I think this set of cuts related to so-called provider taxes, these are taxes and assessments on hospitals and other healthcare providers. It's used by states to finance a portion of the cost of Medicaid. They draw on income taxes, sales taxes, other revenue sources, but this is one of those funding streams that supports existing Medicaid programs. And if you make it much harder for states to use these taxes to finance Medicaid, then that's a big budget shortfall. And states have to balance their budgets, unlike the federal government. So that means big Medicaid cuts, whether it's cutting eligibility, whether it's cutting optional benefits like vision and dental for seniors and adults, whether it's cutting home and community-based services for those with long-term care needs, whether it's slashing provider rates, including provider rates to rural hospitals that already operate under thinner operating margins.
Mm-hmm.
They're going to have to make all these painful choices that are going to result in, harm to individuals who rely on Medicaid, the providers that serve them, as well as other parts of the state's budget because of all the pressures this is going to create in terms of reduced federal funding. And so, that's part of the design of these type of proposals, where the federal government can say, oh, we didn't directly cut these benefits or cut eligibility, but it's the inevitable result of the kind of provisions, the kind of cuts that are included in the law.
Mm-hmm. And I think it's really important for me to say this, is that I don't care what color your state is, and people have heard me say this, I'm so tired of red and blue, because at the end of the day, everyone's in the same pot where this one is concerned. It does not matter if you are a Republican or a Democratic-led state, the impacts will be felt regardless.
Yes. I mean, if a rural hospital cuts staff, cuts services, has to close its doors entirely, that affects everyone in the community in terms of their access to needed health care, irrespective of who they voted for, their political affiliation. And they're going to have to travel much farther to find the health care they need, including labor and delivery services, whether it's for emergency care or for complex medical conditions. And if they have to go so far out of their way to get the care, it's going to be much harder for them to avoid serious, unnecessary health outcomes, that could be potentially fatal.
Mm-hmm. I had a conversation this morning with a gentleman who was with an economic development commission in the state of Kansas. And we were talking about the fact that their critical access hospital closed their OB services. And we talked a little bit about some of the reasons why. And I said, well, how many births, like less than 100. And I said, well, that's one factor. Then how many of those births were Medicaid coverage? I mean, so people need to understand that financially just it can't be sustainable. It's not sustainable. All right. Before I let you go, Edwin, I mean, right now, I said earlier, everyone's been call your Congress, call your member of Congress, call your member of Congress. And it just feels like even the smartest people giving the best data, it wasn't being heard. At this point, I wonder, now that these cuts are written in stone, and I know things can happen because there's this timeline for things. So everything isn't by design, not going to happen all at once. Are there any advice that you can give our listeners in terms of, first of all, just really understanding the impact in their own community and their state? And what else can be said? Is there anything left to say for your state, local officials to help them understand, guide them through this process of not making it a bad situation worse, I'll say?
Yeah, I think two things. One is, now that this has been signed into law, these are provisions that are taking effect, some upon date of enactment, maybe some in a year or two. There are, hospitals, other government officials at the state and local level. Now they're starting to run the numbers, and they're estimating the direct harm, the direct hit on providers, communities, and of course, individuals who rely on Medicaid, and being able to promote that as a way to ensure accountability, right? Members of Congress voted for this, and it passed, despite widespread opposition, both from the public generally, but from various stakeholders back home in their districts, and being able to really emphasize what this means in terms of direct harm to communities, to health systems, and so forth. Separately, I think it's also critical to push back against a lot of the misleading rhetoric, the falsehoods that are being issued by the administration, by members of Congress who voted for this bill. Many of these arguments, many of these claims are wholly inconsistent from each other. So there are no Medicaid cuts, no one will be harmed. Oh, but we are taking away coverage, but we're only taking away coverage from undocumented immigrants, but undocumented immigrants are not eligible for Medicaid. They never have been. This is all about fraud and abuse, even though this is really about taking away coverage from many millions of people. So none of the arguments make sense. None of them hold up under even a couple minutes of scrutiny, but being able to push back on that because those arguments are being made to try to inoculate those responsible for passing this legislation and all of its huge damaging Medicaid cuts.
And as we're seeing so many people that didn't even know they were on Medicaid because of the fancy name that was given to it at the state level. All right. So I would imagine, Edwin, you're going to keep writing about this because you're waiting for these numbers to come in. So where can folks follow you? Because I really encourage them to do so. You've got some really good stuff out there. Yeah,
it's a ccf.georgetown.edu. So I'm with the Center on Children and Families. We put out a lot of Medicaid and CHIP research. Once we do have final numbers from the Congressional Budget Office, we will be putting out a pretty lengthy, detailed explainer of the Medicaid, CHIP, and marketplace provisions in this legislation.
Oh, well, can't wait to get our hands on it. I know you guys are great. We're always keeping our eye out, and we'll make sure that we share that with our listeners as well. And we'll put links on our website to make sure people know where to find you. Edwin Park, thank you so much for joining us. I do appreciate your time.
Thank you for inviting me.
Okay, for the rest of you, do not go anywhere because up next, we are back with my conversation with Shawn Martin, Executive Vice President and Chief Executive Officer of the American Academy of Family Physicians for his take, as well as Nathan Baugh, Executive Director of the National Association of Rural Health Clinics. They're each going to share their perspectives about the One Big Beautiful Bill Act. We'll be right back. Sit tight.
What's the first thing that comes to mind when you hear rural? Is it agriculture, recreation, country, or maybe even elections? Rural can't be defined by one word, one place, or one population. However, we can connect the dots between rural quality of life and policy. And that's what the Rural Impact is on a mission to do. If your organization advocates for rural policies that contribute to thriving rural communities, we invite you to join our partner network. By joining us, you can tap into a wealth of resources, expertise, and a network of like-minded organizations. Discover how we can help you expand your rural reach and share your impact. Visit theruralimpact.com to connect with us. That's theruralimpact.com.
Hey, Shawn Martin, Executive Vice President and Chief Executive Officer of American Academy of Family Physicians, and Nathan Baugh, Executive Director of the National Association of Rural Health Clinics. Welcome to you both to the Rural Impact. We are very grateful to have you here today.
Thank you.
That's great, you guys. Well, listen, there's some things going on, I hear. So we have a lot to talk about. Shawn, I'm going to start with you. I'm really, again, grateful because we don't really get to hear so much the physician perspective on all these matters. We hear a lot of organizational, policy-focused people and so forth. And so I think at the end of the day, I tell people, nurses don't grow on trees and doctors don't appear out of the woodwork. So there's a great deal of impact, if you will, because of what we're going to be talking about today, among other things, the passage of and signing into law, H.R. 1, better known as the One Big Beautiful Bill Act, and how it will impact family health physicians practicing in America's rural communities in all settings. And Nathan will get into the settings that you're familiar with, but Shawn, can you just give us a big overview of what you're hearing from all of your members, where they were before and where they are now? And then maybe later on, we'll talk about how we move forward.
Yeah, well, thank you, Michelle, so much. I appreciate the opportunity to be here. And, the practice of family medicine and primary care, generally speaking, in the United States has been, pretty tense over, the last 5 or 6 years for a variety of reasons. One is, relatively stagnant payment rates from both public and private payers, and escalating administrative function that's being imposed upon practices from insurers and other entities. But another downward pressure has really been, the aging of the population and the prevalence of disease, particularly chronic disease, in the population, which is what family physicians do. It's why they love family medicine. But it also, takes more time to take care of those patients, and time is a commodity that many of them just don't have these days. So when we think about, the provisions of the legislation that we're going to discuss today, a lot of it is, community focused for my members. I mean, they're, we always like to say they're on Main Street. They're not necessarily in the hospital. They're taking care of communities and families, and things that put up barriers or make it harder for individuals and families to access the healthcare system. Our members tend to view very negatively. And I think we just saw a series of those in this bill, just the barriers being erected to give people that already had a substantial number of barriers to accessing the healthcare system a few more obstacles to overcome. And I think it's not always known. Family medicine, is the largest contributor to the rural physician workforce. About 18% of our members practice in a truly defined rural community. They're not out there alone. There's a big team that takes place. The rural ecosystem is very much, centered and successful when it's a team-based approach. But a lot of our members do provide care to rural communities and rural patients. And, this is going to make it harder.
Shawn, in the circles that I travel, everyone knows I work in rural health for my day job. I mean, it's increasingly difficult for recruitment. And so we'll talk about that a little bit later. But I did read, I've been following your material that you all have been putting out. And there was, in the Senate's version of the reconciliation bill, there was I would say a tiny step in improving access to primary care, but it's kind of like, I liken it to dental floss for a lifeline. Dental, right? So it's like primary care through 1 year increase to Medicare physician payment for 2026. What does that mean? What is the dent? Does it do anything?
Yeah, I mean, obviously, more financing in the system is always better than less financing in the system. And I think, that's kind of how we've approached this. But, physician payments under the Medicare physician fee schedule are about 30% behind inflation over the last 2.5 decades. Physicians of all specialties took about a 2.8% real dollar cut in 2025. So, this puts the majority of that money back in, but it's still sliding further and further behind. Inflationary increases in labor and practice expense. There was another provision maybe we can get into later. There was the HSA provision that was specifically designed to help, connect individual patients and families with an HSA account to primary care, which we're pretty excited about. It's not necessarily a rural specific policy, but we do think it's an opportunity to create a more meaningful connection between individuals and families and primary care. And we're kind of curious how this will play out over time.
See, in my mind, I would hope that the infrastructure would be in place. So it's like building the plane while you're trying to fly it.
Yeah.
That's kind of the way I have a lot of analogies these days, and I'm trying to keep it clean for a family show. So Nathan, I'm going to jump to you because your director of government affairs, whom we've had on the podcast before, Sarah Holman, has done a really excellent job, I'm sure, with the help of other team members, kind of detailing the impacts to rural health clinics, which is a primary setting for family physicians in many ways, and talking about, these Medicaid cuts, which is critically important for you guys to continue doing. But I want to shift to the how you guys are feeling about the Medicaid cuts, and then talk about the Affordable Care Act reforms, which I think is unfortunately being kind of buried underneath the drumbeat of Medicaid cuts. Do you know what I mean? So talk about what those changes mean for rural health clinics. But first, I do not want to assume all of our listeners understand the difference between, for example, a rural health clinic, FQHC,
right,
and maybe a hospital-based. So why don't you go there first and then to the next one?
Okay, sure. So rural health clinic is similar to an FQHC, but they are very different programs. We have similar reimbursement mechanisms on the Medicaid side, different reimbursements on the Medicare and Medicare Advantage side. And FQHCs have, I would say, more requirements, but then they also get grant dollars. RHCs have less requirements, but we're not as grant funded as FQHC. That's like the quickest summary there. Very different programs. Sometimes we're hand in hand because we are written together in the law in many places. Other times we're kind of in different places. FQHCs can also be urban and rural. Rural health clinics, of course, only can be rural. So that's the quickest summary there. Hospital, like outpatient departments, as you mentioned, I guess the way I think of it is just being a hospital outpatient department in a rural area, or even just a doctor's office in a rural area, doesn't automatically mean you're a rural health clinic, even though you are, like, an average person might call it a rural health clinic, and that would make sense. It's a formal program. So a lot of rural health clinics are owned by hospitals. So you could have like a hospital outpatient department that flips into a rural health clinic, as an example. So that's baseline understanding. In terms of how we're feeling about the bill, I think we are concerned, and, obviously the biggest impact for us is going to be the anticipated rise in the uninsured uninsured patients.
Mm-hmm.
And that is going to hurt us in particularly because unlike the FQHCs who get grant dollars to help them care for uninsured, we don't really get any assistance. So that is just a financial hit for our rural health clinics that we're going to have to bear the brunt of. I am guiding and I'm trying to help the rural health clinic community be on top of the Medicaid work requirement changes going forward. At this point, it's here. And so I think the best thing our practices can do, our rural health clinics can do, is help your patients not get caught up in this red tape that we know is coming to prove you have community engagement. That means getting involved at the state level. It means getting involved with your patients and doing the best you can to help your patients navigate the red tape that is coming. And then finally, the third question here on the Affordable Care Act.
Mm-hmm.
I think you're totally right. This is going to be the major healthcare battle, in my opinion, heading into the end of the year. There were some people, myself included, who thought that they might address this issue as a part of the first reconciliation package, but we have enhanced premium tax credits that are set to expire at the end of this year.
Mm-hmm.
And these enhanced premium tax credits are credited for taking the ACA enrollment from about 12 million to over 24 million in the last couple of years. They were put in during COVID. And so if they expire, it's anticipated that number is going to come down by, I've seen the CBO say, I think 4.2 million. So it's another 4.2 million folks that could lose their insurance. And that's if they expire. The politics of this, I do have some numbers on this. 157% of that enrollment growth has been in red states, and only 36% of that enrollment growth has been in blue states since 2020. So the politics of this are tricky, and I don't know exactly where we're going to land. I think just letting all of the enhanced premium tax credits expire is maybe unlikely, and I think that perhaps they will claw back some of those at the end of 2020, but perhaps not all.
You bring up a great point, Nathan, and Shawn, I'm going to go over to you because maybe the politics are tricky, but the policy is not. And everyone who listens to this podcast knows I say often, all roads to quality of life are paved by policy. I don't care what color, red or blue. I wake up every morning hoping someday that we can just erase all this ugliness because, Shawn, at the end of the day, work requirements mean, I just read something this morning that it just breaks my heart every time. More patients will forego care.
Yeah.
All right. And so what's that mean for your constituents?
Yeah.
They don't want sicker patients.
I think it's twofold. I think I'll do the selfish one for my members first, which is, as Nathan said, physicians and other healthcare clinicians are going to have to help patients navigate this enrollment process that is going to be more and more difficult to do. And in fact, there are certain provisions inside the work requirement eligibility criteria that require some attestation from the healthcare entities that see them. So the administrative function is going to increase. I think one of the things that I'm always most disappointed in work requirements is that it's never accompanied by continuous, 12-month continuous enrollment. It's, they still make them do this twice a year, or some states I think now make, 3 times a year. And that's just, challenging. It's challenging for the individual and the family, and it's also challenging for those that are advocating on their behalf. Look, Michelle, I always talk about barriers to care, and, in rural communities, there's a lot of them. I mean, you have distance, you have socioeconomic, a lot of times you have, language or cultural barriers. Like there are a number of barriers to care that just exist without us trying. So I am always most disappointed when we try to put up other barriers. And this bill does that in a variety of ways that are just going to cause people to forego going to see their family physician or going to see another clinician type in their communities. Diseases will progress or go undiagnosed. Cancer screenings don't happen. Ultimately, the individual will have worse health outcomes, and the healthcare system itself will experience a higher cost. And This has been proven. This is not just Shawn saying this. It's been proven over and over and over again in programs in the United States and around the world that, continuous access to primary care improves health outcomes and reduces on a per capita basis healthcare spending. So the opposite of that is going to happen. And that's just too bad.
In closing rural hospitals, I would say, is one heck of a barrier to overcome. I mean, very few of them reopen. And under these circumstances, I don't predict that would be an option for so many of them. All right, let's switch over to something else, because another thing that came out of this is this Rural Health Transformation Program, which is the number kept fluctuating, went from 15 to 25 to 50. What is it? $1 billion that are going to go towards, to help with things like, and I'm just going to kind of read off the list here. Improve access to hospitals, healthcare providers, and services. With all those other barriers, I'm not sure that will happen. It's supposed to improve health outcomes, prioritize the use of new emerging technologies, and so on and so forth. But the administration of the program is yet to be known. It's very subjective. Part of it will go here. A lot of people are saying it's not going to go to the right places. I'd like for both of you to just kind of give me your sense of how this will impact, again, those who you're serving, and really, with all the unknowns, what can you tell us what you know about it?
You want me to take that
Go
first?
ahead, Nathan.
Yeah, I mean, it's super vague. When I saw it, that was kind of the thing that I noticed. I also noticed that the states have to put together a plan and apply for this money by the end of this year. So
yes, it is July.
go forth and get your plan done, states, if you want access to this money. I don't know. That seems like a quick turnaround for state government to pull off. Maybe they can impress me. I'm looking at those state plans for detail as to how this is going to eventually get spent. And then, I presume the secretary will approve or ask for edits in those state plans. And that's kind of when we're going to see those details. But right now, I think it's super vague. And I also think that this money is not necessarily hardwired to go to rural. So it's being called sometimes the Rural Hospital Fund. And I don't think that that's right, because RHCs are defined in there as a rural facility. FQHCs are defined as a rural facility. So it's not just hospitals. But the uses of the funds don't even direct the funds to those the defined rural facilities. The use of that definition is just about how it's distributed across the states, not necessarily how the money must be spent on those end facility types. So it's something I'm watching. I don't have all the good answers. I'm kind of waiting I want to take bets as to which state will be first to submit their plan, which state will have their act together the most.
Yeah, but we'll be watching that too. And Shawn, there's no provision in this, from what I've seen. There's no provision that provides support for the clinical services. So again, I ask, what are you hearing? And maybe what would you ask for? I mean, as we're out here advocating, what needs to be considered?
Yeah, I have very similar reactions to Nathan. I think, one, I would have never designed this way. I don't know that it's a good policy apparatus aimed at, alleviating or mitigating the other provisions of the bill, which I think was kind of how it was presented. But, our general attitude is it now exists. So, how are we going to work to shape both the design and distribution of these dollars? There's nothing in there that says it has to go to any provider type. But, it says it has to go to the provision of, promoting rural communities or helping rural communities. And, I think the one thing that we were encouraged in the criteria is around the workforce. Do you have programs aimed at increasing the rural healthcare workforce? I think, that obviously is a place that we'll be interested. But, the challenge is, always with grant programs when it goes to the states, is the states want to negotiate with the fewest number of entities possible. And those fewest numbers of entities tend to be quite large, and they tend to maybe have a rural presence, but they tend to not be rural based. And, and I don't blame them for that. It's easier to negotiate with one or two large entities than to negotiate with 500. So, I think we all have work to do to make sure that money, goes where it has the highest impact. And, I think rural health clinics, rural primary care practices certainly are at the tip of the spear of impact as far as community improving health outcomes in those communities.
Mm. Yeah, you're right. And there's one little line here that says it's also can be used to recruit and train more healthcare clinicians.
Sure.
And before we move on, Shawn, I mean, I'm just curious, recruitment and retention is something, and Nathan, you've heard this, like there's so many programs and so many formulas and so many people have answers about how you do that. But at the end of the day, they're human beings. And I wonder what you're hearing, from the human side of this, how all of this legislation might be impacting just there's a will for people to provide this amazing rural focused care. I wonder what all of this is doing to maybe detract those who want to do a career in rural health. They might say, man, this is just too hard.
Yeah, I think, this one's tough because it's an individualized decision. But, our data would suggest to us that rural practice for a large number of family physicians is very attractive because it affords them things that are very value oriented to them. It's a connection with the community. It's a comprehensive practice environment. You get to have care across a longitudinal time period of a lifespan. But the things that make it hard are isolation, lack of other specialists to, collaborate with and refer to, uncertain presence of other healthcare providers or entities in your community. So when the rural hospital closes, that's really hard for rural primary care to stay. They lose a lot of supporting services and other physicians. The thing I always stress about those that go to the rural communities and why losing access to care and an increased number of uninsured and increased administrative burden is it gets harder to exist from a time perspective in that environment. So when you can move into a suburb practice or, a different type of location and someone does all that for you, that becomes more and more attractive as the rural practice setting becomes more and more challenging. But
I'm seeing more and more people say like the concierge kind of model where all of these things don't matter because you get paid a lump sum and, you get to pick and choose which patient base you want to engage with, if you will. I do want to just shift over really quick to the provider tax because I'm not going to ask you both to do the 101 on what it is. Sure. But at the end of the day, this is another big topic that we're talking about. And Nathan, let's just start with you. I mean, in terms of the provider tax, I am quite frankly, full disclosure, not quite sure how the rural health clinics kind of fit into this equation. But if you wouldn't mind just kind of sharing with us the impact of the provider tax provisions in that they'll be restricted, no new provider taxes. What is that going to do to you all in the rural health clinics across this country?
As far as I'm aware, there's going to be no direct impacts, but money is fungible, right? So to the extent that it's going to squeeze Medicaid programs' ability to pay hospitals a certain amount of money, Medicaid programs might look to cut other provider types equally if they're going to have to cut hospital payments. As far as I'm aware, most RHCs aren't directly tied to the provider tax the way perhaps some other provider types are. So it's going to be an indirect impact, and for us at least, in that the state's financing mechanism is just under greater pressure, and that pressure will radiate throughout the system. So and I would say that for anyone that's not directly, getting a provider tax or something like that, the pressure will radiate through the entire system.
Mm-hmm. Shawn, is there anything on your radar screen where this is concerned?
Yeah, I mean, I agree with that. And I think just less money means that different choices have to be made. And, most of the time those choices are pretty negative. I think the other thing that, when you talk about the juxtaposition of a bill like this, many of the substance use disorder programs and rural outreach programs on opioid use disorder and, those types of things are all funded through this enhanced, financing that states are able to achieve because of the provider tax. I mean, that money is reinvested back into specific community needs or, that are localized. And I think that completely got lost, in this debate around this bill, the mental and behavioral health services, the things that are helping individuals in these communities really are a byproduct of that enhanced financing mechanism. And if that money goes away, I mean, it's just a logical step that some of those programs are going to go away.
And we were making, strides. We were making strides in addressing these things. And what strikes me so much is just the whole conversation around making America healthy. At the end of the day, so much of this is the opposite of what we would think would achieve that. So kind of shifting before we close out, there's a lot of information. I have been in healthcare for over 30 years, and I've never imagined in my life the changes coming out of HHS that what we're seeing. For me, it's almost unrecognizable. And I've been to the HRSA headquarters and work with a lot of folks in that agency. And so I would like to just kind of shift to that and talk about any concerns that each of you have. I mean, Nathan, yours is a bit, I'm sure, different, but just related to some of these massive policy changes. Shawn, there's been a lot of pushback from the physician community about things like child vaccination studies, access to COVID vaccines for children and pregnant people. And I'm just wondering how the medical community, so many of the providers I talk to, don't want to have a political conversation. And yet now this is so encroaching upon their expertise. How are your members addressing, being pushed to, now we've got politicians telling us how to practice medicine and what's right and wrong. This has got to be a real thorn in some sides. Yeah,
I mean, it's frustrating. It's also, counterproductive. And I will tell you, our association, AFP, my job, I take very seriously. Our job is to, do the best we can to deal with the environment in which they're practicing so that, they can focus on the most important thing in their practice, which is the person in front of them. And I say this to our staff all the time. It's our job to deal with all the rest of the things to make the world better so that the person in front of them is really all that matters on a day-to-day basis. Now, with that said, healthcare is really hard in a status quo situation. So when you start really disrupting large portions of that status quo from an operations perspective, it gets even harder. And that's just where we are. There is not a single aspect of the practice of family medicine that's not being disrupted in some way, either administratively, operationally, clinically. And I think, I wish it wasn't this way, Michelle. I really wish it wasn't this way. There are ways to make policy changes that are not as disruptive, but it's the world we're in. And we all of us, have to do the best we can to mitigate that disruption and make sure that we are putting people in a position to pursue and achieve health. And I don't know another way. I wish it was easier, but it's hard right now. But that goal remains the same.
Yeah, absolutely. Nathan and I work with a lot of rural health clinics and their staff, and it's getting harder and harder for them. They get pushback. They don't have the support that they need. What are some of the things that you're hearing, and that some sort of strategies that the rural health clinics are doing to kind of combat disinformation? To, patients have questions. I mean, they're going to be asked to answer a lot of questions that may be out of their wheelhouse because they just want to stick to patient care.
Yeah, I'm going to pass on the clinical side of it. I don't know what confusion some of the messaging is creating necessarily. I will say from the sort of the financial end of things, we have concerns with some of the proposed HHS budget reducing, as an example, the number of regional offices. It's unclear if it's going to drop the number of CMS regional offices from 10 to 5 or just HHS. That might be a distinction without a difference. But we already face really long enrollment times. Like the process, if you said, Michelle, I'm opening, you probably know this. If you want to open an RHC today, the process can take quite a bit of time to get properly enrolled in Medicare and Medicaid. And the regional office plays a big role in that. So we're concerned that there's going to be a bigger bottleneck there. And it could take upwards of a year, almost 2 years, in order to formally enroll as a rural health clinic. So that's a concern that we have with the reorg, which I know was not your last question, it was part of your initial question. So that's just one aspect we've seen. Like, I often get into like coding nuance stuff with CMS, and I will say it hasn't felt more efficient at getting answers.
Sir, so
lately.
you're such diplomats, you two.
Well, there's always, like, CMS does the best that they can. And the people I work with are great. And I do think that sometimes they are held back by decision-making timelines above them. And it feels like we had some changes that went into effect January 1 and some others that were supposed to go into effect July 1. And it just doesn't feel like we have had the same amount of guidance that we normally get from CMS when changes to this degree are made. So that's been my experience thus far. So hopefully the reorganization, if it does happen, I hope that it leads to more efficiency down the line. The last thing I'll say on this from the politics standpoint, a lot of the reorganization of like getting rid of HRSA and creating AHA, I'm not a legal expert, but I believe Congress is going to have to go along with that. And that battle I'm expecting to play out certainly as a part of the appropriations cycle that we're heading into, beginning October 1st. Will Congress pass a CR that blesses the restructure? I kind of doubt it. And though I do have to say this other last thing, because it's in the budget to no longer fund state offices of rural health. And I think that that's a catastrophe. Rural health clinics are very reliant on their state offices of rural health. And so we are really hoping that doesn't happen and that Congress, says, thank you for that recommendation, Mr. President, but we're going to fund state offices of rural health. So that's really one of the major things that we're watching as part of this approach.
I sure hope so. And maybe they'll do it in time for National Rural Health Day this year, which is always the third Thursday of November, because that is catastrophic. Really, I understand how much. Okay, for both of you, and Shawn, I'll start with you. At the end of the day, there's all sorts of things. It's not over till it's over. I mean, this is pretty permanent. Everything they've rolled in here, I think, has been done very deliberately to just put it all in one trunk, lock the key, and revisit it whenever someone gets that key back. But advocacy also has to happen at the state level. One of the things that I wrote about yesterday was the fact that counties are going to be impacted by this. County finances, local economies. When a rural hospital closes or a rural health clinic, when a rural hospital closes, oftentimes the rural health clinic goes with it because it is part of it. So there's a lot that can be done to bend the ear of other policymakers. Again, here's where we are. Here's who we're appealing to. There's no other body responsible for this but policymakers. So with that said, for those who are in health professions, what is in your advocacy's toolkit that says, listen, there's a lot of damage that can be done from this. How do we start to kind of minimize some of that damage? What are some things that your members and others can really take with them to say, we have to keep talking. We can't just accept this and say, we'll see what happens. That's my opinion.
Yeah, I think there's I think we're still unpacking, but I think generally speaking, we're very concerned about the disconnecting people from healthcare coverage. Mm-hmm. Even though there are some provisions in the bill I said at the top that are probably really favorable to primary care, the direct primary care and HSA. But, that's a marketplace that has to be developed over years. And it may prove to be a very beneficial shift in creating greater access to primary care. And time will tell. We're very supportive of that. But I think, what we're going to start working with at the state level, especially if the ACA tax credits were to expire, you're going to see a large number of uninsured that's going to come with a incredible amount of economic burden on the healthcare systems in states. That's going to make insurance premiums for just everybody else, including the employer market, fluctuate and go up. So I think we're going to talk a lot about what we talked about in 2006, 7, and 8, which is people being disconnected from healthcare coverage has rippling healthcare effects, but it also has pretty substantial economic impacts on our communities and states and the country. Another thing that we're going to continue to talk about is from healthcare coverage is not going to make people healthier. And there's a number of studies out there that shows there's really two things. As I said earlier, one is a continuous relationship with primary care, and the other one is continuous healthcare coverage. Individuals that have those two things over prolonged periods of their lives have better health and they spend less money on their healthcare. So, we have a lot of work to do. The good news is, from a wonky DC perspective, they gave us a lot of dials to turn in this bill, so we can turn them, trying to turn them down. And, I think there's opportunities to do that, but it's going to be really challenging in the current political environment.
And I want people to connect the dots too, because at the same time we're talking about this with the disinvestment and social drivers. And I talked to someone the other day that says we're not even allowed to say that anymore, in our grant application. So when we take away food assistance and nutrition assistance, and we defund housing programs, and we don't invest in transportation, all those things are indicators, as we all know, to health. And then with that, the kind of the criminalization, if you will, of the penalties for providing care for immigrant populations. That's another thing that we didn't have before. So it's just compounded. I mean, I wish I'm usually such a bright, sunny, sunshine personality, but not so much these days. Nathan, what's your kind of takeaway for those who have it still within them, and I hope they do, to advocate and, quite frankly, keep their skin in this game to make sure that we don't, lose on every front?
Right. Well, as you both said, the action is moving to the states for sure on Medicaid. But I would say know your timelines. Many of these provisions kick in over time. The work requirements don't begin until 2027. Provider tax phase out stuff begins in like 2028. But some of the most aggressive savings and the most of the pain is going to be felt in 2032, 2033, 2034. And that's a lifetime politically from now. So we're not predestined to get there. I mean, when they passed the Affordable Care Act, there were all things in that bill that were passed initially that never actually came to fruition because there were changes later on. And so you could take the same approach with this legislation. Just because it's something is scheduled to begin in 28 and get worse by 2033 doesn't mean that we have to just accept that. There's a lot of politicking and policy making that can happen between now and then. And, I do think a lot of this can be unraveled. And the other thing is just for us to retain our credibility. I think it's important to really know those timelines, because if someone's like, well, hey, I haven't really seen it yet, it's like, well, yeah, that's because it hasn't kicked in. So we have to educate the public, and we can't forget about this in a couple of years. And we have to be, hey, remember, because of the one big beautiful bill, now this thing is happening because we haven't reversed it or whatever. So we have to make that connection, I think.
Yeah. And I'd say make sure that we keep the staffers engaged, because sometimes they outlast. And I think that's so important. I'm going to just both read you guys something before we end. I read a blog today by a gentleman named Jim Bialik. And Jim, I apologize if I said your name wrong, but this line really stuck out to me. And he said, whether Medicaid survives this retrenchment will not be measured in abstract budget lines. It will be measured in real lives. And I hold that very close to me every single day. Real people are going to be harmed by not having access to health care. And nobody wants that in my circle anyway. Shawn and Nathan, I'm so appreciative for your time. To both of you, you are welcome back. I mean it anytime. We'll be watching. Nathan, you and I have some bets that we like before it was passed.
Yeah, what state?
What state? So we'll keep our eye on that. And again, thank you to you both for your work and the service that you do for your constituents. It's greatly appreciated.
Thanks so much.
Thank you, Michelle.
You're welcome. My sincere thanks to Edwin Park, who you heard first up, and also to Shawn Martin and Nathan Baugh for their time and certainly for their insights. As you heard, there remains a great deal of uncertainty about the extent of the harms and the impact of this new legislation on America's rural communities. But we do know with all certainty there will be considerable challenges moving forward. This bill does not remove roadblocks. As you've heard, it certainly does place new ones in front of us that we need to continue to have these conversations about. But before closing today's show, I want to make sure that I extend this very serious invitation to you. I've been thinking about this a lot and talking to our whole team here at the Rural Impact. Over these next 6 to 12 months, we are going to be really taking a look at the impacts of these policies from a state and county level, so a rural county level. And that means we want to hear from you directly. Those of you who are working to balance your own budgets and figure out ways to make sure your rural communities can continue to be served for those lifeline programs, if you will. So If you are a county or a city government official, if you work in the area of economic development, housing, healthcare, food, security, nonprofit, faith-based organization, again, if you're serving a rural community, send us a note. We really do want to understand in just a few sentences about how these policy shifts are impacting your rural community and your ability to do the important work that you do. And you can reach out to us by simply emailing us at info@theruralimpact.com. Again, that's info@theruralimpact.com. And if you would prefer, please go ahead and follow us on social media. You will find us on Blue Sky, LinkedIn, and Facebook. That's where we're spending all of our social media time at this point in time. And we'd be happy if you would send us a direct message or tag us, and we will be sure to respond to you. As long as you're being nice and not using profanity, I'm going to put that out there for you. So some days you feel like you want to use it, but not on this show. And if you're interested in partnering with us, like our new partners at the National Association of Rural Health Clinics, and you're going to be hearing more about that coming soon, just visit again, theruralimpact.com, click on the link for partners, and learn all the ways that we can help you expand your rural reach. As always, we do appreciate the feedback that you send us through notes. I just cannot tell you how much it means to me to get your messages through LinkedIn and other platforms. And of course, we do appreciate those donations that are coming in because they do help us continue to produce these dot connecting conversations. So again, I am Michelle Rathman. And until I see you again, I'm always going to say this: please take the best care of yourself as you possibly can and those around you. We will see you soon on a new episode of The Rural Impact.